Now, we've heard a lot about airway, especially this morning, and I'm going to introduce you to a couple of concepts that have been touched on but not discussed a lot. But as I was introduced to airway, I didn't plan to become an airway orthodontist, and I still don't think I am. I don't think that's what we practice in our practice. I'm an airway-aware orthodontist, but when I first started looking at it, the most surprising thing is what you're seeing on the screen right now is a normal airway. And when I started looking at the cases we were treating at 7, 8, 9, and 10, these are the airways that I was seeing. Was this a coincidence, or was this somehow related? It's the chicken and the egg argument. Is the airway contributing to the malocclusion? Malocclusion contributing to the airway being small? I think these are so intertwined that our scientific minds want to pull them apart and make it simple. Just get the teeth straight and everybody will breathe right. Just make the airway big and OSA will go away. And it's not going to be that simple. This is a bad airway. It's one breath. That's 2. All night, this kid is trying to sleep and recover and grow, and their brain's trying to process things. You can imagine how difficult that must be. If all you do is identify those children and serve as advocates for them and their parents, you will change the lives of a lot of people in your practice. So what do we know so far about this? You've seen a lot of really great research, especially over the last hour and a half, but I'm going to start you with some baby steps, and I'm going to show you just a couple of articles that might open your eyes from an orthodontic perspective. And I want to introduce you first to what's called MCA, or the minimal cross-sectional area. And this was done by a physician named Shendell, out of Stanford as well. And it's simply just a documentation study, looking at 1,300 patients of all ages, and just measuring one simple thing: the smallest circumferential area of the airway in the pharyngeal space. Here's what Shendell found. The airway does get bigger with age, at least in this sample. And it gets bigger by approximately 10 square millimeters per year of life. So on average, if we're using this Shendell study as kind of, here's 1,300 patients looked at over time, airway gets bigger from 6 to 20, which is a good thing. And this is why a lot of physicians will wait on doing anything that's airway related, because they know the airway's growing, things get better, let's not take tonsils out or adenoids out, everything's going to resolve, they'll be breathing fine by the age 20. The problem is after 20, everything gets worse, and the airway gets smaller. That tube, that flappability that Dr. Liu was talking about, if that tube is really floppy and it's small, it's harder to keep it open even if you turn up the velocity. So the goal for me is I want to try and get that tube as big as we can get it. Now, there's been some correlation studies with how big that tube is relative to OSA. And this is what the correlation studies will tell you. Anything that is less than 50 square millimeters is correlated strongly with OSA. And then all the way up to above 150, there's no correlations. Now, this measurement is not the diagnosis of OSA, nor is it the cause. It's correlated. There's a lot of things we have to look at. Here's an interesting study between snorers, people that are just loud sleepers, a lot of air passing through their airway, and it's audible, but they're breathing well. And it compares those snorers with a group of patients that actually have true obstructive sleep apnea. It's a CT study, so it's not cone beam CT, but medical CT, and here's what they found. They divided the measurement areas into the retropalatal area and the retroglossal area. And what they learned is that the differences between their snoring group and the OSA group is all of the narrowness was in the retropalatal area, where they didn't find any significance in the retroglossal area, which is curious. Here's another study that looked at MCA a slightly different way. And what they found is the width of the MCA had slightly more correlation than the AP. So the airways were smaller in the OSA group, but they were also more narrow width-wise. I love that Dr. Liu and Dr. Yoon both pulled up that coronal view of the airway. We forget about that in orthodontics. We've so rarely looked at coronal views or transverse views. We're so used to looking at the sagittal. And there's a lot to that transverse. So perhaps the wider that airway is, the better. It's not all AP. Incidentally, for that study, all the subjects, their MCA was in the retropalatal area. So again, kind of going piggyback off of Dr. Liu and Dr. Yoon's information, this upper airway, nasal pharynx, velocity of air, retropalatal area, that's what's driving that oxygen through this floppy zone. The solutions for adult OSA are pretty crappy. Those on the left side are supposed to be the easy ones. Those on the right are a little bit more involved. I think the work that Dr. Liu's doing is pretty spectacular. These are gonna change as we evolve. But they all are not very good options. If we can avoid this disease, we'd love to. Now, everybody wants to get to this question, get to the answer of this question. What if we could prevent OSA? And as orthodontists, we really want the answer to this question. What if we could develop the airway? Can we? And I think there's been a lot of evidence proposed over the last couple of days that we have some influence on this. We affect how jaws grow, we affect how teeth erupt, we can affect how tongues live. All of those things can, down the line, affect the airway health. And so I think we have the ability to have an influence. This is a maxillary palatal expansion study that's looking at nasal airway volume changes. And just like Dr. Liu and Dr. Yoon were talking about, increasing that nasal volume, everybody went up with the expander. Nobody had a decrease. The more air, the more velocity going through that nose, the less collapsible your tube is going to be. 15% increase with expansion alone. So if you're an orthodontist and all you do is expansion, you're actually helping nasal volume. So you're helping airways whether you know it or not. Does that affect how that airway grows over time? Perhaps. From an orthodontic perspective, we have to think about the structures that involve us, which again, we're tooth focused, of course. But this paper, and Rebecca Bachau in her beautiful keynote yesterday mentioned this paper, the minor study. I'm going to break it down in super simple terms. Here's what this study did. It was a cone beam CT study. They looked at the coronal slice of the jaws at the first molars. And they divided the sample up into 5 categories. Normal control on the far left, unilateral crossbites, bilateral crossbites, superior convergent, which we don't know very much about in orthodontics, and then finally on the far right, inferior convergent, which I don't see very often. It's the superior convergent that's the tricky one for us. That's where the maxillary molars are leaning out towards the mandible and the mandibular molars are leaning in. Now here's what the academicians did on this study. They measured the skeletal width, not the dental, the skeletal width at the maxilla and the mandible at that first molar coronal site. Keep in mind, clinically, and this is how I was trained, when I do a clinical exam, if I'm looking at molars, maxillary narrowness meant crossbites. If there were not crossbites, I did not identify maxillary discrepancies, maxillary narrowness. I didn't see it. And on my study models, if there wasn't a crossbite, I didn't see it. Normal controls, no crossbites, and superior convergent cases look the same. They looked the same to me for the first 10 years of my career. I didn't see anything wrong with them. The roots and the axial inclination in the coronal slice are very important. And to me, the transverse dimension, since I've been in three-dimensional orthodontics, the transverse dimension has become the most important dimension to me as an orthodontist. Here's what the study revealed. The normal controls, the maxillary skeleton on the lingual, was about 1 millimeter smaller than the mandible. That's the normal control. But look at the superior convergent cases. No crossbites. The skeletal discrepancy was greater than that of unilateral crossbites. And for most of us as orthodontists, we'd treat unilateral crossbites all day, but we'd leave the superior convergent alone. And this took a lot of retraining in our community for me to tell the pediatric dentists, don't just wait for a crossbite. Send me everyone at 7 and let me measure. Because we're gonna find a lot of superior convergence. And this is the take-home message from the paper. Patients without crossbites can have significant discrepancies that might warrant treatment. And this happens a lot. And it affects airway when you treat it. Now, if your only take-home from all of the airway content is identifying these massive obstructors, tonsils and adenoids, you will have a win-win situation when you get back to the office. Because if you identify a Maddie in your office, you will change those parents' lives. Guarantee it. So if all you're doing is screening for tonsils and adenoids, doing snore checks, talking to the mom, you're gonna change some lives. Now, what happens when you get involved with either TNAs, tonsillectomies and adenoidectomies, and expansion? This study sums it up very well. What they did is they had a group of patients, all of whom needed a tonsilloidectomy, adenoidectomy, and expansion. And they divided the sample into 2 halves. One group would get the TNA first, expansion second, and the second group would get that flipped. Expansion first, then the TNA. They did AHI, they did sleep studies on all the patients at every time point, beginning, after the first procedure, and at the end. And here's what they found. The good news is all the patients improved, which is awesome. So on average, they were able to get AHIs of 12 down to less than 1, which is great. AHI for children should be 0. And RDI, which is a slightly more sensitive test of how well you're sleeping, RDI went from 21 all the way down to 1.6. That's a big improvement. Now, if you're just doing expansion and you're not addressing tonsils and adenoids, what's your effect on AHI? And so I was interested in this group that had orthodontics first. And you'll notice that the AHI and RDI decrease with just expansion. And that's great, because even if you're missing the tonsils and adenoids, you're still improving AHI by 51%. If you just do the TNA and you're not doing expansion, you're improving it by 55%. Now, what happens in the real world is those two procedures often live in different doctor worlds. When you put them together, it becomes very effective. 91% decrease in AHI with expansion and TNAs.